I want you to start thinking about oxygenation on a conceptual level. It's a process that facilitates carrying oxygen to tissues and carrying carbon dioxide from tissues. Different concepts are interrelated. Adequate perfusion is necessary to deliver oxygenated blood to tissues and remove metabolic wastes from tissues, so there's that interrelationship going on there. Adequate oxygenation is needed to support intracranial function. Intracranial regulation supports respiratory function. Same way, metabolism, motion, tissue integrity, nutrition, sleep, they all require adequate oxygenation to function properly. Understanding of these interrelationships between concepts will help you recognize risk factors and increase your awareness when conducting a health history. When you interview a patient, collect subjective data about patient's present health status, past health history, family history, personal history, and psychosocial history because it may affect the functions of their lungs and respiratory system. You also need to collect data regarding patient's home, work environment, and recent travels to see if they have been exposed to any respiratory irritants or infections. Your textbook does a good job in giving some good starting points for asking these interview questions. Please read and practice those. As you conduct a health history related to the respiratory system, you need to ask the patient about common risk factors associated with lung cancer and follow up with additional questions as needed. One of the major risk factors for lung cancer is tobacco smoking. If the person is or has been a smoker, determine the number of pack years that the person has smoked. Cigarette use is documented by pack years. A pack year is the number of years that a patient has smoked multiplied by the number of packs of cigarettes smoked each day. If a patient tells you that he or she has smoked half pack of cigarettes a day for 40 years, it would be recorded as a 20-pack year of smoking history. Use of pipes, cigars, marijuana, chewing tobacco, or snuff is usually recorded in the amount used daily. When reading problem-based history questions, please pay attention to rationales given under those questions in your textbook because it explains why of those questions. For example, why is it important to ask about the color of the sputum? Because white or clear sputum may occur with cold, viral infections, or bronchitis. Yellow or green sputum may occur with bacterial infections. Black sputum may occur with smoke or coal dust inhalation. Rust-colored sputum may occur with tuberculosis or pneumonia. Inspect patient for appearance, posture, and breathing effort when you are doing your regular examination. The patient's appearance and posture should be relaxed. The posture should be upright. Breathing should be quiet, effortless, and at the rate appropriate for the patient's age. Remember, when counting the respiratory rate, each inhalation and exhalation is one breath. Observe their breathing pattern and symmetry of chest expansion. Your textbook has a good figure of different patterns of respirations. Please become familiar with those terms and what they mean. Inspect patient's nails, skin, and lips. General color of skin and lips should be consistent with the patient's ethnicity. In dark-skinned patients, cyanosis is assessed by inspecting the oral mucosa and lips. Cyanosis is bluish discoloration of the skin due to lack of or low oxygen levels in blood. When auscultating for breath sounds, request the patient to sit upright if possible and breathe deeply and slowly through the mouth. When you have the patient breathe with mouth open, it avoids sounds made by air going through sinuses. Establish a hand sign with your patient to communicate any dizziness as they take deep breaths. If they raise their hand, you should wait for dizziness to subside before proceeding with process of auscultation. Always clean the diaphragm of your stethoscope before placing it against the person's skin to auscultate breath sounds. listen to the full cycle of inspiration and expiration. Always compare one side to the other. Stay away from bony parts of the patient when listening and move aside large tissue if possible. Remember that right lung has 3 lobes, and mid-lobe on that side is more on a lateral side. Your textbook shows 8 landmarks anteriorly and 8 landmarks posteriorly. In this course, we will focus on using 6 landmarks anteriorly and 6 landmarks posteriorly, along with 1 on the right lateral side. We are mostly focusing on normal findings in this course. However, we are going to talk a little bit about adventitious or abnormal lung sounds here. If an adventitious or abnormal lung sound is heard, have the patient cough and repeat the auscultation or listen to their lung sounds again to determine if the sound has changed or disappeared. Diminished or absent breath sounds may be heard in patients with collapsed or damaged alveoli, which may occur in patients with COPD, emphysema, or if a patient is having a severe asthma attack. Let's go over the adventitious sounds covered in your textbook. Your first one is crackles. These are fine, high-pitched crackling and popping noises heard during inspiration and sometimes during expiration. These are not cleared by cough or changed when a patient changes the body position. They were known as rails previously, so you might see that term. Wheeze, high-pitched musical sound similar to a squeak. It's heard more commonly during expiration, but may also be heard during inspiration. This one occurs in small airways. Bronchi, it's low-pitched, coarse, loud, low snoring tone. It actually sounds like snoring. This is heard primarily during expiration, but may also be heard during inspiration. Coughing may clear bronchi. Pleural friction rub. These are superficial, low-pitched, coarse rubbing or grating sounds. It sounds like 2 surfaces are rubbing together. One example I can think of is if there are 2 balloons and you rub them together, that's what it sounds like. This is heard throughout inspiration and expiration, and this is not cleared by cough. Remember one thing, that before you decide that the patient has an abnormal lung sound, it might just be a sound distortion due to bumping of the stethoscope tubing against something, or if the patient touches the tubing. It could be patient is cold and shivering. If the stethoscope is placed and unintentionally moved on the patient's chest hair, sound may get distorted. If there are any extra environmental noises due to rustling of their gown. Go ahead and listen to your own breath sounds using your stethoscope, and let's hope they're clear to auscultation.